Welcome to Ethics for Lunch for October. My name is Mark Hughes. I'm a faculty member in the Department of Medicine, also in the Berman Institute of Bioethics, and I co-chair the Hospital Ethics Committee. We're excited to have you here today. Today we're going to be talking about decision-making capacity. Before I have the panel introduce themselves, I just want to acknowledge the generous gift from the Freeman family to help support this session and all the subsequent sessions this year and the lunch that you're eating. So we very much appreciate it. It's in honor of John Freeman, who was head of pediatric neurology here for many years, expert, world-renowned in treatment of epilepsy in children, and also the first chair of the Ethics Committee at the hospital, as well as an instrumental figure in the development of the Berman Institute back now almost 20 years ago. His wife, Elaine, was Vice President for Corporate Communications here, and she's given this support in honor of John and his contributions to clinical ethics. So we're very much appreciative of that. Let me have the panelists introduce themselves, and then I'll talk to you about our topic.
I'm Patrick Wood. I'm the clinical director for the Department of Psychiatry. I'm also one of the attendings on one of the FIPS proactive psychiatric consultation teams in the Department of Medicine.
I'm Pete Linkram. I'm a nurse practitioner in cardiac surgery and a member of the ethics committee.
Lourdes Carapoma, neurocritical care. I'm an acute care nurse practitioner and also a member of the ethics committee.
And I'm Susan Longley. I'm one of the attorneys for the health system, senior counsel for the health system, responsible for risk management over the baby campus.
We'll have Matt Norvell come soon. He's a chaplain in the Children's Center, so we'll hear from him when he arrives. So I'm going to give you some introduction to decision-making capacity, an important concept. When we're doing informed consent, we have to make sure the person is capable of making decisions. So the overall objectives for this session are going to be to talk about how to assess for capacity, identify the resources and tools that can be used in that assessment, identify when it's appropriate to consult psychiatry to help in those assessments, and then if a person is determined not to have capacity, how do we involve surrogate decision makers for those patients and help those surrogates make decisions on the patient's behalf. So the reason we decided to have this for one of our fall sessions is just over the summer, we have a new policy that was approved by the medical board on the assessment of decision-making capacity. So when we do ethics consults, there are often questions that arise of, could you help us to help figure out if this person can make their own decisions? So this policy is intended to help the clinicians in the hospital to do that. And then at the end, I'll show you some of the appendices, which are some algorithms that you can work through when you have questions about the person's capacity. It's obviously building on a well-established policy that we've had for many years on informed consent. So capacity is talked about in the informed consent policy, but anytime we're proposing a treatment, a surgery, a blood transfusion, whatever the case may be, and we need to get informed consent, one of the obligations of the clinician is to make sure the person can make those decisions. So obviously, well established in clinical ethics and in law that patients have the right to make their own decisions. So if they have the capacity, we should engage them in that decision-making process. We don't have to document capacity. It's assumed that most patients that are coming to us already have capacity. So if a patient is able to understand, able to give their own consent, automatically in the medical record and our assumption is that they have capacity. It's only when it's going to be questioned where we might need to do further assessment. So either we think they can't make the informed decision, or we know that we need to seek another person, a healthcare agent or a surrogate decision maker, where we need to document that the patient lacks capacity. So when we're talking about informed consent in general, there are going to be threshold elements, information elements, and then the consent elements. So first of all, before we even start informing the patient, disclosing information to the patient about, let's say, a proposed surgery, we have to make sure that they are entering into this process voluntarily, that they're not being coerced into it, that any of our framing of information is not manipulative in terms of getting their consent. They really have to make a voluntary choice for themselves. And then they have to have the capacity to make the decision. For the clinicians that are doing the informed consent, there are going to be various requirements for disclosure. So we use the reasonable person standard. What would the average person need to know about risks, benefits, and alternatives in order to make a treatment decision? And I think that also includes that the clinician is giving a recommendation. So while we might talk about a range of options or a range of alternatives for treating their condition, we're giving a recommendation of what we think is appropriate or best for them based on our clinical assessment. And as we disclose that information, we also have to check that the patient has understood what we've given them. And now ultimately they have to make a decision, either yes, I consent, or no, I refuse. Based on what you told me, I decline on your recommendation. And if there is that authorization, then we can proceed with the treatment. So Clarence Braddock is a clinical ethicist, has written an article about the elements of disclosure, and some of it is articulated in law, but he also highlights these 7 points. That there should be an active participation by the patient in the discussion and in the decision. They need to know the nature of the decision, what the natural history of the disease process would be if it were left untreated, what are the alternatives, the pros and cons of each of the options. Are there any uncertainties in the decision? What are the probabilities of success? But also, are there things that we just don't know and we can only know over time as we institute things? Checking that, telling the patient, we need to make sure you understand the information I'm giving you, and we give it in a language that is understandable. And then ultimately eliciting the patient's preferences. It's not just the decision, but how does this fit into their life plan, the context of their life and their values. All of that's going to be important when we're disclosing the information. And when there are these questions, we're going to have 4 elements that count as having capacity. So again, I keep coming back to the idea of understanding. The person has to comprehend the medical information. They have to appreciate it. So how is this significant for me in my own situation? They have to have reasoning ability, so they have to have the cognitive ability to process the information. If you're talking about pros and cons and risks and benefits, can they manipulate that information in order to come up with a reason for their decision, and how does that fit in with their values? And then lastly, they have to be able to communicate a choice, actually make a decision. If they vacillate, if they hem and haw, if they never actually make a decision, we might question their ability to make decisions or have capacity. So they actually have to reach a decision and communicate that to us in some way. It may be verbally, it may be written, it may be blinking their eyes, it may be other forms of communication. We just have to make sure that they have communicated that choice. So with that, I wanted to hear from the panel about their experiences with thinking about capacity, either in their role on the ethics committee or in their other roles as staff and employees here at the hospital.
Okay, well, let me tell you a little bit about the psychiatry perspective on it. We, as Joe Bienvenu is here today, reminded me this morning, we probably get called most often for capacity assessments, studying delirium or some kind of cognitive disorder. Probably the times that we are most helpful, well, let me back up. The reality is psychiatry doesn't have to see every capacity assessment. I think there are times when people think that's true, but it's really not the case, and that's going to be addressed a little later in this talk. The times that we can be probably most helpful are times when there's concern that there's an underlying psychiatric disorder or psychiatric symptoms that are affecting a person's decision-making. And the other time, I think, we can be most helpful is sort of in a gray zone where there's just a sense that this doesn't quite fit very clearly, and you want kind of a deeper dive to look at some of the thinking that's going into decision making.
So from an ethics committee perspective, I've been on the committee for a few years, and if I could think of a generic capacity assessment ethics consult, it would be that you have a patient who has agreed with what the teams wanted to do for however long, and then suddenly disagrees, often in the context of something that would potentially cause them harm if they didn't get it done. So something like dialysis. The team recommends dialysis, the patient says, I don't want dialysis. Oftentimes that triggers the consult when maybe they had not had capacity for some length of time before that, but they were agreeable. So that's one element. And then the other would be that we often have to reiterate in the process of the ethics consult that it's perfectly okay for people to make bad decisions. We have a responsibility as clinicians to maintain patient autonomy, and even though we disagree or maybe their family disagrees with what decision they're making, they have the right to make the wrong decision.
From a provider perspective, there are many, many challenges that we encounter to assessing decision-making capacity. From the perspective of the ICU, many of our patients lose consciousness, and in those cases, they appear to be quite straightforward. But those are really not the cases that really stick with you. It's the challenging ones that do. Those patients that are conscious, that appear to have capacity until you dive deeper into the issue or the treatments and you realize that they may not have a very clear understanding of the risks and benefits and their own personal values and how it fits within that context. So those are really the challenging cases that we encounter, particularly in the ICU setting, and I know many of you here in the acute care setting have also encountered those situations as well. We're going to be talking a little bit about that and how to address that, how to get resources to help you in assessing capacity in those situations later on in the talk.
So from a legal perspective, normally we're called when there is a perceived problem, right? So we don't necessarily get involved at the very beginning of the process, but whenever we have an opportunity to talk to folks, I always like to tell people that when should you start thinking about capacity? I think you should be thinking about capacity the first moment you lay eyes on the patient, because it becomes extremely important if you think that perhaps this patient doesn't have capacity. You have to start marshaling the resources, right? So you don't have to run down the path of who are the family members, how do I get in touch with family members. You don't have to do all of that, but you contact social work to assist, right? The idea is that you try to be proactive so that you avoid that urgent situation where now you truly believe the patient lacks capacity and you don't have a decision maker. So that's what I like to tell folks. So start thinking about capacity the first moment you lay eyes on the patient, and then you call us if there's a problem, and we can walk you through. We can't help you in the determination from a clinical standpoint of does this patient have capacity. However, we can certainly help you in trying to ascertain exactly who would be the legally authorized decision maker if the patient doesn't have capacity.
Are there any examples or questions from you all, experiences you've had where capacity has been an issue? So we make sure we address those over the course of our time together.
So we've encountered situations over Bayview on the ethics committee there, and I'm sure it's happened here as well, where the decision-making capacity is not something that's just one and done. It might be the case where somebody is sort of vacillate in and out. So I was curious what the panel's impressions are of those situations that kind of move targets on that.
It's absolutely true. It happens all the time, especially in the ICU, where we need to reassess. And it also worsens with decision complexity. When procedures are becoming more and more complex, they're even difficult from a provider perspective to really provide clear information and to assess a good understanding and to have that patient fit that within the context of their own personal values and goals. Yes, we continue the capacity assessment each time there's a decision that needs to be made, absolutely.
Oh,
Oh, sure, yeah, no, we run into this all the time. We run into cases, well, a lot of cases where if it's an underlying delirium, for example, it clears up and, decision-making capacity is restored. We've seen, as Loris was saying, even with a patient who maybe has not changed significantly clinically, the decision being asked is more complex and more simple. We have to kind of reassess their ability to make that particular decision. We had one not too long ago, a patient who we felt didn't have the capacity to make a fairly complex decision about medical treatment, but it actually came over to psychiatry, was clinically basically the same, but radiology wouldn't consent them for a very straightforward study because the flag in ethics said they didn't have capacity. So we had to go and clarify with them. Now, they don't globally lack capacity. So that's the kind of thing we run into.
Yeah, there may be cases where the person has permanently lost capacity and it's more global for all decisions, but then what's more often the case is, depending on the simplicity or complexity of the decision to be made, it will be fluid. And our EPIC documentation system may only have full capacity or incapacity, but it may be decision specific. And the clinicians just have to appreciate that a radiology procedure they might be able to consent for, major treatment or surgery, they may not have the capacity to. So that sliding scale notion. Any other questions or experiences?
Yes, I have a question. Most of the cases in the hospital, teams are involved, and this definition doesn't have like a degree of a scale. So what I believe what would be the patient's understanding, perhaps the other provider would believe that is not enough understanding. So my question is, when two providers do not agree about the capacity assessment, what would be the third step? Having a third opinion, or who providers turn into with the responsibility of choosing when there's intra-team disagreement?
So Susan moved to the line.
Yeah, so that's kind of a legal question. So, again, the presumption is that everyone has the ability to make their own decisions. And so when there is a disagreement, if you have two providers, one says yes and one says no, it's yes, right? So you're erring on the side of the individual's right to self-determination. I would say that if you have a situation where you have a provider who's very, very concerned and still saying they don't believe the patient has capacity, and you have another one who says, yes, they think that they do, that's a situation where instead of just getting the tiebreaker, you're probably going to want to get legal involved, and you're going to want to get an ethics consult also. Because honestly, the law really doesn't even contemplate what happens. So you take a poll, you have 5 providers, and you take a poll and the majority wins. The law really doesn't address that.
But you do need the two physicians, licensed physicians, to determine incapacity. So if there is only 2 physicians and one says yes, one says no, they have to talk to themselves or get ethics and or legal involved to help in that decision.
Very public dispute in the paper for the last several months, which resulted in Hopkins having a very large monetary decision against it, was just this sort of a case where Hopkins claims it explained all the things that would go wrong, and why the mother should agree with certain things, and she did not. So what do you do in that case?
I turn to Susan.
That was a very difficult case, needless to say. But I think it illustrates how important it is to try to get it right in the beginning, right? And all we can do is, we can't ensure that we're going to be right 100% of the time, but we have to ensure that we've done our due diligence and we've done the best we can. The question is, why do we care? Again, it's a patient right, but then there also are legal ramifications, ultimately. Not only if you are getting consent from a patient that maybe doesn't have decision-making capacity, and we should have recognized it and addressed it, and I'm not saying that that was the case in that case. But if you don't recognize that the patient has decision-making capacity, it's not a problem until there's a poor outcome, right? And then it becomes a problem because they're going to attack the fact that there was not truly informed consent, the patient didn't have capacity. So then it turns on liability, right? So again, it's just, we have to do our best, we have to do our due diligence. Ultimately, if we're found in some way in the future that we were wrong in our assessment, we still, I suppose we could potentially be found liable from a medical malpractice perspective, but certainly we have we've done all we could. But it's very difficult to defend a case where if there was a question, you didn't go down the path of really trying to assess and seek assistance in the determination, the ultimate determination. And that's why, we talked about ethics consults. That's why we talked about reaching out and getting your, the lawyers involved as well. So we can't always ensure that there won't be ramifications in the future, but we try to get it right in the beginning.
The literature certainly supports, good communication, establishing a therapeutic relationship, sound documentation of what's been discussed can certainly help.
Absolutely.
Is there any?
I had a question about, for example, refugees that come from outside the country, that perhaps they come from a country where there's been a civil war and they've had such limited access to formal education that it's not a reasoning incapacity, but almost the gap and the lack of formal education becomes the incapacitating factor.
I can comment a little on that one. We run into that actually a fair amount, and it doesn't have to be from someone or with someone from abroad. We actually find that here in Baltimore City. A patient might just be incapable of understanding. They don't have the wherewithal to process the information. It may be a fairly complicated decision or set of decisions. And in that setting, they really don't satisfy the criteria. That you can't say that they understand the information that's been presented to them. And that's when we start recruiting family and others to help make some decisions.
It is ultimately a clinical judgment of whether you think they understand and have you simplified it down to a level that they could understand, irrespective of their health literacy. Could you go back to basics and just try to build the information to an understandable level for them? And obviously, if it's a refugee that's from another country that has English as a second language, you want to use medical interpreters and others that could help facilitate better translation and making sure it's as understandable as possible. All right, so let me just summarize a few of the things that have been talked about. As Pete mentioned, sometimes we just go along. If the patient's saying yes to everything, we just assume they have capacity. Obviously, there's going to be that presumption of capacity, but just a person that always goes along, you still need to assess their capacity. If they ask little questions or really don't involve in the discussion, you start to think, are they really understanding what I'm telling them? Or are they just nodding their head and saying yes to appease us? There's also the distinction, we didn't mention it, but this idea of competence versus capacity. So competence is a legal term, adjudicated by a court. So a judge says you're not capable of making any decisions, financial, medical, otherwise. Whereas decision-making capacity that we're talking about is for medical decisions, and that is a clinical assessment done by the clinicians. And ultimately, for the competent person or the patient that has capacity, we want them to make decisions, and we want to protect the incompetent or incapacitated patient from making bad decisions. So it really becomes important to assess their capacity. We've talked about the sliding scale notion of capacity. So again, this waxing and waning over the course of a hospitalization. Even over the course of the day, they might be delirious in the morning, but a little clearer in their mental status later in the day, or long hospitalization. It may change with the complexity of the decision, the seriousness and the uncertainty of the decision. We have to gauge whether they have the capacity for each decision. There may be certain red flags that will come along that say we really need to do a more formal assessment, a bedside assessment. So a mini mental state exam score of less than or equal to 18, the total score is out of 30. There's the other one called the Montreal Competency Assessment, MOCA, which also goes to a score of 30. If you're getting below 18, there's probably a pretty good chance that your cognitive abilities to do the reasoning and so on may be compromised. Obviously, if a person's for their whole life had developmental disabilities, intellectual disabilities, that might be a place to think whether you need to do a formal assessment. Doesn't automatically mean they don't have capacity, but you have to do an assessment. We talked about the delirium or the cognitive impairment day to day. We've talked about the idea of irrational refusals. It seems pretty clear what the right thing to do, the best thing for the person, the clinically appropriate decision, and the person is saying no, without any logical relationship to either their values or the goals that they've stated. They want to live, but they're refusing the life-sustaining treatment. How do we figure that out? And we have to go back to the assessment of capacity. It may be a family member raises concerns. I'm not really sure that mom or dad is making the right decision or has the ability to make decisions. There we might think about doing an assessment. Patients lost it in the past. They seem to have it now, but we need to do a more formal assessment. Or as I said, they've had this limited engagement and discussion or decisions. You may want to do a more formal check of it. So what you first have to do is figure out what needs to be decided. What is the decision the person has to weigh in on? Obviously try to do it in a private, quiet setting so the person's not distracted. They can pay attention to the information disclosure and the conversation. Assessing the patient's primary language. Really define the choice, the pros, the cons, and the alternatives. So that's our basic structure. We have in the literature, Paul Applebaum is a forensic psychiatrist who's written articles about determining capacity. He has a nice algorithm in the New England Journal that I'd refer you to, where it says, what are the questions you could ask the person to probe into these 4 domains of capacity. And another tool that's available is called the Aid to Capacity Evaluation from Toronto. And that's what you have in front of you, if you picked up one of our handouts. And it's a structured interview where you take notes of what the person has said and then score that based on these various domains and ultimately make a determination whether they have capacity or not. So the audience participation part of this is you're going to score some interviews. As the instructions here say, domains 1 to 4, you have to evaluate whether the person understands the current medical problem, the proposed treatment, the other options, including withholding or withdrawing treatment. Then you go to domains 5 and 6, whether they appreciate the consequences of their decision. For all 1 to 6, you start with open-ended questions. If you don't get an adequate response to the open-ended question, you might ask a closed-ended question. For domain 7, you want to assess if there are any mental health issues that might be a factor in how they're judging the information, whether they might be depressed or have psychosis. And then there are going to be ways to assess for that. If it's in the depression realm, hopelessness, worthlessness, guilt, or punishment. In the psychosis dimension, are there any delusions or other aspects of a psychotic disorder? We record these, try to write down the exact responses of the patient, and again, we start with the presumption that the person has capacity, And it's only after hearing all this information might we say it's either uncertain or they lack capacity. So you're going to hear a series of interviews. We have our patient, Mr. C, just joined the table. And I'm going to tell you about Mr. C. It's also in your handout there. He's a 7-year-old widower. His wife died 2 years ago. He has a daughter and 3 sons. His relationship with his children is marked by considerable conflict. He was recently hospitalized with gangrene in his right foot and lower leg. Problems with his foot began 3 years ago when he had an infection in a toe in his right foot, which became gangrenous. It was then that he discovered that he was diabetic. The toe was amputated. Last year, he bruised his right leg while getting into a bus. The bruise developed into gangrene, which resulted in an operation 6 months ago where a portion of his foot was amputated. At that time, an arterial bypass was done to decrease the likelihood that gangrene would recur. He went from the hospital to a rehabilitation center where he remained for 5 months. It was found that he had gangrene again on the remainder of the foot. He was started on intravenous antibiotics with no response. A below-the-knee operation was suggested to him. On the morning of the operation, he shows up for the surgery, and he withdrew his consent. He went home to stay with his daughter for 3 days. He's now been brought back to the hospital by his daughter. Mr. C has been unhappy since the death of his wife. He does not wish to burden his children, and he does not believe the operation will cure him. So now he's had this refusal of the surgery, which you think is, going to help, treat his condition, and an interview ensues. We're going to bring the chairs up in front. Now you'll see us, and we need 2 mics. We need one. I need a script. Okay, so take notes, and then we're going to ask you after this interview, does the patient have capacity? Mr. C. Hi, Mr. C.
Hello, doctor.
What problem are you having right now?
Well, my foot hurts and I can't walk at all.
What's the treatment for your foot?
Well, what everybody else has told me is that they're going to cut my leg off below the knee.
Are there any other treatments?
I know that I was taking antibiotics. Is that what you mean by other treatments?
Yeah.
Yeah, I was taking antibiotics.
What are your other options?
Well, I do know that I could say no, like you can't cut my leg off unless I sign that paper.
And what can happen if you do have surgery?
If I do have surgery, then they'll cut my leg off, and then I'll end up in a wheelchair.
And what can happen if you don't have surgery?
Well, I would still have my leg. But they tell me I could die. I could have blood poisoning.
So why don't you want to have surgery?
You know, I've had a full and complete life. Like my wife has died. I don't want to be a burden on my kids. I don't want to be in a wheelchair because I need to be independent. I think it's okay. It's time for me to let nature take its course.
Okay. Does Mr. C have capacity to make this decision to refuse surgery? Show of hands, yes. Show of hands, no.
There's a disinterest.
Or unsure, uncertain. Okay, for our uncertain folks, do you want to have any comments about what other?
Yes, I would want to get a little bit more information on, is there a depression that's driving his decision making?
What other questions might you ask to get at depression?
So I would want to ask if, I would want to go through the protocol. I'm a psychiatrist, so I want to go through the protocol of doing an evaluation to determine if there is a depression present. And then I would want to ask if there were a depression present, I would want to see how severe it is to see if it's causing some distorted reality, distorted thinking, and if that could then be impacting his decision making. Because there has to be degrees of the depression. Just because you're depressed doesn't mean you're not, don't have the capacity.
Okay.
In the back.
Thank you. So he seems less clear about the outcome of not having the surgery than you might like. So he didn't say that he was likely to die. He said, that's what people are telling me, as if there was a failure to cognitively recognize that really was a consequence. So I want to check to make sure that there wasn't a kind of denial about the consequence of not having the surgery, which would allow him to take that choice.
So if he said, I could die if I don't have surgery versus people tell me I could die, you think there's a distinction there that a certain element of distrust or denial of what they're telling me. Is there another comment? All right. Well, we're going to leave you in suspense of whether he has capacity or not, or whether we need to do more clinical investigation. But now, rewind. Now we're seeing Mr. C totally afresh. He's refused surgery, and we have our next interview.
Hello, Mr. C.
Hi.
Your team asked me to come and see you. What problem are you having right now?
I just don't know. I don't know. I've been here a long time.
Do you have a foot problem?
I guess, I mean, I can't walk, so yeah. I'm missing toes.
What's the treatment for your foot?
I don't know, you're wearing the white jacket, why don't you tell me?
Can you have an operation?
Yes, they can cut my leg off.
Are there any other treatments?
Nothing has worked. Nothing, I wish there were other treatments, nothing's worked.
Can you take antibiotics?
Oh, yeah. I've been taking antibiotics, and they say those have been helpful.
Can you refuse surgery?
I can.
What could happen if you have surgery?
You know, I really don't know. I'm not completely clear on that.
Could surgery help allow you to survive?
Well, yeah. I think that's probably why they were suggesting it.
What could happen if you don't have surgery?
I guess I'm so sorry. There's just so many things that have happened. I really don't know.
Can you get sicker or even die if you don't have surgery?
Yeah, I guess probably, yes, I could get sicker. I guess I could die. There's a lot going on.
Tell me, why don't you want to have surgery?
Well, nothing seems to work. I just keep coming in and out of the hospital, and things aren't getting better, and every time I come in, I lose toes or something, and just nothing's helping. And my wife's been gone for a while, and there's nothing for me at home, and so I'm just really sad all the time. And I don't know why I go through more stuff like that.
Sorry to hear that. What is your vote this time?
How many think the patient has capacity? Okay, how many, should we do unsure next, or no capacity?
One person thought I had capacity.
Or two, I saw two.
Two.
All right, how many say he lacks capacity? And how many are unsure? The majority are unsure, okay. How about those that said he has capacity? The two, are you brave enough to speak up, or shall we go to the lack capacity? The two people that said yes capacity? Thank you.
I think he has a pretty good idea of what the outcome would be. I just think he doesn't want to say in precise words, I could get worse, I could die.
So he understands, he seems to understand the consequences.
I think he does.
He's communicating a choice of, I don't want surgery. He's heard about the alternatives and seen that they haven't worked. So he's sort of reasoned through those alternatives as well. And then he's fitting it into the context of his life that he's now a widower. He's sad at having the loss of his wife, and is fine about making the decision for no surgery. So our 4 criteria are kind of there. Now, do people want to object to that? We can't have our psychiatrist answer everything.
I'll stay on.
So, how many think he lacks capacity? There were a couple. So, do you want to say anything about that? Wait for our mic.
I think he's done a really good job with the second interview to show that he is depressed, he is overwhelmed, he is feeling hopeless, and I think he has a passive death wish because, it's like he's planning to die. I've lost my wife, there's nothing for me at home. We already know just from reading the summary that what kids has, there is a conflict situation, and helpless, hopeless, overwhelmed, depressed, feels like he has nothing to live for, and he's ready to die.
Yeah. Wait for the mic.
Doesn't seem any presentation, though, of other interventions that could happen. I mean, there are things that could be given to him to make his life easier. He could have an electric chair, he could have certain kind of help at home, or you could think of a lot of things that haven't been mentioned. Nor has what he will go through before he dies been mentioned, because clearly what he would probably most like is a physician-assisted suicide, but that's not mentioned either.
Yeah, so there could be more information and disclosure. He hasn't heard about these other options. All he sees is loss of my leg and I'm in a wheelchair, but no opportunity to think about improvement in function or a motorized wheelchair or help at home or other things that could give him a better quality of life if he got the gangrene taken care of. So that's one, but to the other point of somebody talking to him about management of his sadness and feeling loss of hope and helplessness, that could also be addressed. I'll go to the back first.
Thank you. Since I'm older than this patient, I wonder if anyone has talked to him at any length about the consequences after amputation. Why would he have to be in a wheelchair?
Yeah, so even, right, there could be prosthetics arranged and, a rehab to get him ambulatory again. Since depression has been raised, Dr. Triplett, we rely on you to say what other things would you potentially explore with him?
Actually both points I thought were really good. It's not clear, but there's some red flags that kind of shot up there. And sometimes our job, when we're called in to see patients with similar problems, is to try to disentangle how much of this is normal demoralization, the kind of frustration and low mood and the kind of feelings that come with sort of in the realm of normal for a major life event, versus something else, versus a syndrome of major depressive disorder or some anxiety disorder. Is there something else complicating the picture? So I think that would, based on these answers, it would require a deep dive to make sure we're not missing something.
All right, so for those that said unsure, we'll agree with you that we need more information. I'm going to, in the interest of time, move on to the third interview. Have you have your scoring sheets and We'll see what Mr. C looks like this time.
Hi, Mr. C. My name's Pete. I'm a nurse practitioner. Just going to ask you a couple questions about your surgery. So at this point, what do you understand is your most serious medical problem?
I don't know. I don't even know why I'm here, to be honest with you.
Okay. Do you have a foot problem?
I don't know.
Okay. So I think you do have a foot problem. So what do you think is, and in fact you've had several, you've had some toes removed, so you've had an ongoing problem with your foot. What do you think is the treatment for a problem like what's going on, how your foot looks like it is now and after the toe is removed and the infection?
It does look bad. I really don't know what kind of treatment. It looks really bad. No, I think it hurts.
Okay. Can you have an operation for that?
I don't know. That's probably up to you. I don't know.
And are there any other treatments for that, as you understand it?
I'm not certain. Again, I'm not exactly sure why I'm here.
Okay. How about antibiotics? Have you heard about that? I mean, do you think that might be an option?
I've heard about antibiotics. Should we do that, do you think?
Well, what I'm trying to do is get an idea of what you understand in this whole process. So you've been back a couple of times for this foot.
Yeah.
So from your perspective, I mean, I'll make my recommendation later. I'm just trying to get a sense of what you understand in this process.
Okay. Yeah.
So do you understand that that's an option, that antibiotics are an option for you?
I don't really understand much of what's going on.
Okay. So one of the reasons you're here is because we had set you up for a surgery for that foot.
Goodness.
Do you understand, can you refuse that surgery?
I don't know. You'd have to talk to my daughter, I think. I don't know if I can do that.
Okay. Do you think that surgery could help you live any longer?
Maybe. I really don't know why we're doing a surgery, though. I'm not sure.
Right. Part of the reason that we're doing the surgery is because we feel like in order for you to live longer, in order for you not to keep having these problems, we would like to remove your foot. Do you understand do you have an idea of what could happen after your foot is removed? Like, what are some of the consequences of having your foot removed?
I can't even imagine what it would be like to not have a foot. I really don't know what kind of consequences there would be.
Okay. And let's say we didn't do that. We didn't remove your foot and it stayed the way it is now. What do you think would happen?
I don't know. That seems like that'd be good, though, because removing my foot seems like that would hurt.
Okay. And do you think that you might get sicker if your foot isn't removed, if it stays the way it is now?
I don't know. I mean, I've got my foot right now, and it seems okay.
Okay.
So I don't know.
Do you think maybe you could die if you didn't have this removed? Has anyone talked to you about that?
No, nobody's talked to me about that. I don't know.
So at this point, you've made it clear that you don't want the surgery. Why don't you want the surgery?
I've done a lot of things in my life that I don't need to keep going. I don't know if I deserve to keep going. It's been a really bad life. I don't even think I need to go any further.
I'm sorry that you feel that way. They'll be smoking for fun.
You seem very nice.
Okay, how's our voting? Those that say yes, he has capacity. Those that say no, he lacks capacity. Those that are unsure. Okay, why don't we take a couple of the unshores? Carol, are you willing to wait for a microphone?
I think this gentleman sounds depressed and bewildered, and foggy, you know, so I'm unsure.
Whether the depression is enough to say that he's lost capacity?
He sounds hopeless. And I think sometimes the easiest thing is to just give it, you know, it's hard because someone sounds hopeless, you can't say that they lack capacity. But you also can't, you're also challenged to try to explore a little bit further what's going on. I mean, it's
Okay, so you need more information.
That's interesting. Yesterday, as we were discussing this, Pete brought up, because as we were doing that, I thought it would be just as easy for me to say, yeah, sure, yeah, I understand, yeah, I get that. And to just endorse everything that he brought up. And that doesn't mean that I necessarily have a better grasp on what I'm doing. But often in our informed consent processes, if somebody's not putting up a barrier, then we just keep plowing forward and put something in front of them.
So you could say yes to everything along the way, but still express all these ideas of hopelessness, and the clinicians might just go along with it.
I could imagine, I mean, am I making that up? Has anybody not seen that? Okay. I could imagine a scenario where that would
So I'm a little bit unsure because I'm declaring that he doesn't have capacity. The next step of management would be like finding a surrogate decision maker. And my question is, he's in pain. He could be in pain. He could have medication, heavy medication, that right now perhaps are clouding his capacity, but it doesn't necessarily mean that he has lost completely his capacity. And I think that it should be like a chance for the patient in case that he doesn't have that he have a shot in deciding if he wants to do surgery or not.
So determine if there are these other extenuating factors that are influencing his thought process, whether it's pain or the effects of a medication, and treat those, address those to see if he becomes more clear-headed to then make a decision.
Because he's sort of like he will continue the conversation, so he will follow, but something like he was lagging. So it could be also like sort of depression, but then I was wondering more, something more physiological, that he's distracted from the question that he's been asked.
Let me pose this question. So you said you mentioned the surrogate decision maker. So if we determine that he lacked capacity, which the majority of folks did, and maybe it's his daughter's the only other family member, and she would be the surrogate decision maker. What would people do if she said, well, I want my father to have surgery. That's why I brought him back to the hospital. Ignore what he says about not wanting surgery, just perform the surgery. What would people do?
Well, I just have a question as far as what kind of time frame do we have? Like, how severe is his physical condition? Because that can then determine how long do we have to try to see if we can get his mood better, to see if he can gain some capacity. But if it's an emergent, like if he's got, you know, fever and all that, and if it's really a decision needs to be made now, that will then determine, does he have capacity right now versus do we have time to see if he can gain some capacity. So if the daughter, regardless of what her decision is, it really depends on really what kind of time frame you're looking at.
Okay. So at least 3 days ago, they accepted his refusal and allowed him to go home. He's back. We haven't heard anything about him being septic or, hypotensive and, in imminent danger of dying. But do we have time to try to get him better if there's depression, if that's in the mix, treating that? Okay. Other thoughts?
Sorry, I might have missed it, but I worry about this guy's cognition, not just depression. The Applebaum article, we love, But Applebaum makes the point that that's the most common cause of lack of capacity, sort of held up by judges, is cognitive limitations, even more than depression. So, I think, I would have been asking him, I would have been doing a simple cognitive evaluation.
Paul's responses are, I don't know, we need to assess his cognition. He doesn't seem to understand, is it because he just has cognitive disabilities? Okay, now we're going to bring in the expert to do another interview. And totally off script, not based on the ACE, but how a psychiatrist on the consult service would come in and ask questions.
Using a script anyway.
And you see, you make your own vote, you see what happens.
All right, Mr. C. So what brings you into the hospital?
My daughter brought me to the hospital.
Oh. What's wrong?
I don't know, she keeps telling me I need to be in the hospital.
Okay, you don't agree with her?
No, she's always in my business.
Okay, what do the doctors say?
I don't know, you've seen all these others that have been through here today.
That's a bit of a clown college, I know.
Yeah.
What's the gist of
They
it?
keep saying that they need to do surgery on my foot. They don't need to do surgery on my foot.
Oh, okay. So that's what they're proposing, they want to do surgery?
They want to do something, they want to cut my foot off. I just need to go home. I just need to go home.
What, did they say why?
I don't understand. They took my toe, last time I was in here, they took some of my toes off.
Yeah, but they don't just do that, I mean, why would they?
I have no idea.
So they haven't said to you,
I have no
here's
idea.
our rationale, this is why we want to remove your
I am a smart guy. I had a business. I've done stuff. And they just came. I woke up, I didn't have any toes.
And you weren't sick before
I
that.
don't understand this at all.
So this is the same thing playing out again. You have no idea why you're here.
My daughter, since my wife left, my daughter just keeps coming back. Oh, Dad, you gotta go to the hospital. You gotta go to the hospital. I think she's trying to get some of my money.
What makes you think that?
Now she says, oh, when you get this surgery, you can come in with us. And then she's making my checks.
But still, you don't know why the surgeon, the other members of the team would want
It seems unnecessary. If you could just, can you help me go home?
to. Well, they asked me to come in and kind of figure out what was it that made you say no to the procedure.
It just doesn't seem necessary to me.
And they've explained it to you, though, why they want to do it.
And they keep coming through, they say it's bad, they say, oh, you could die. People inflate things all the time. If you could let me go home and sit in my living room where I've sat for the last 40 years, I'll be okay.
Well, they said you could die. Did they tell you other things that could happen if you don't have those?
People have been saying that every time I've come in this hospital that I could die. Why should I start believing them now?
Well, it sounds pretty serious.
Well, I mean, if you say so, you got the white jacket, but
Still,
I've not lived my life.
you're the one that makes the
let me go home.
decision.
Just let me go home. I'm trying to make the decision. Nobody's listening to me. I just want to go home.
Okay. So, but they've told you what can happen if you don't get the procedure.
Yes, yes, yes. All the bad things can happen. I understand. Just, could you let me go home?
Let's sort this part of it out first. So, are there alternatives to getting the procedure done?
You could let me go home?
Okay, we covered that.
Okay.
For the procedure, is there anything else that they might?
I've been taking the antibiotics for a long time. I could keep taking those. It's easy enough to swallow a pill in my house.
Okay.
I could keep doing those.
Did they say this is a viable alternative? This,
The one guy said it
Reasonable.
was viable, so I like him.
which one was it?
That's the guy with the beard. I like him.
It's not actually somebody that works here. So what happens if you do have the surgery?
I don't want to have the surgery. If I have to have the surgery, I have to stay here for a long time. Then I go out to live with my daughter. I don't like her kids. She's they're after my money. Like, I just need to go back to my house. That was the last place I was with my wife. I need to be back at my house alone.
Okay. Well, there's something, I haven't really gotten to this reason. Why is it that you don't want the surgery?
I'm gonna be one, look at this, I'm already missing toes. You gonna take another piece from me?
Well, but again, they've
I'm not
explained
gonna have a
to
lot
you-
of pieces left.
Well, but they've explained to you what happens if they don't do the procedure.
Yeah, that's okay.
Okay. And have you've talked to your family about this?
I don't trust them really as being helpful.
Okay.
I'm a 70-year-old man, I don't need my kids' permission to not get a surgery.
All right. You seem suspicious of your family's motives. Can you tell me about that a little bit?
I feel like you're catching on, like I think that they're out to take my money. I built this business and I sold the business and I made a lot of money. I feel like she's trying to get it from me.
Okay. What kind of clues have you had that she would be?
She's trying to get me to move into their house, and sell my house. Oh, maybe I can get power of attorney for you, Dad. Maybe I can do this for you, Dad. I'm getting in my pocket. I don't care for it.
Well, from an outsider's perspective, one would think that doesn't sound very sinister at all. Isn't that what a caring family member would do?
If you met her, she's right over there. You should. I don't know that you can trust her.
Okay. Has she done things in the past that would make you think she's not good?
I did not want to talk about this. The last time I was at their house, they tried to poison me. She cooked a meal, and after the meal I got violently ill and had to go to the hospital. I think she tried to poison me and kill me.
No? So walk me through that. Explain to me, did you get a sense that she was going to try to hurt you in advance?
I tell you, I've been suspicious of her for some time.
Okay. So you think she tried?
She doesn't normally cook. She cooked this meal. Dad, a special meal just for you. And then afterwards, I thought I was going to die.
What did she say? Did you confront her? What did she say?
Yeah, she controls the medications. I can't confront her.
Have there been other times you thought people were trying to poison you?
I don't remember any other time. It's been mainly her. I mean, it's not the first time that she's tried this.
Oh, really? She's done that before?
I'm not exactly sure why my wife died. Yeah.
It's pretty serious. Have you ever gotten clues or sort of signals that something was up, something amiss?
They're always asking for money. They're behind on money. I think she's trying to get money.
So this is a suspicion. This is going to seem like a...
Well, doctor, she's not going to write it on the wall and say, I'm trying to kill my dad to get his money. She's smarter than that.
So this is going to seem like a question completely out of left field. But have there been times that you've heard voices that other people wouldn't hear?
No.
Okay, or maybe seen things that other people wouldn't necessarily see?
I don't remember seeing things that other people wouldn't see.
Have you ever gotten messages or clues or sort of signals from the television or the radio?
I don't remember that at all.
All right. But you just got this sense that she's, I don't want to put words in your mouth, but you say that she's sort of out to get you.
I've felt that way for some time. She's out to get me.
So there's the episode with the food. You're not sure about how your wife passed away.
Right.
What else?
Did you look into that, about how she died?
That's really way outside my realm, though. What else? What other things have you noticed?
She keeps taking me to this one doctor. He's not here right now. He keeps taking me to this one doctor. He's the one that keeps wanting to take pieces of me off.
Okay.
I think that they've got something, I don't know, they're in cahoots together somehow.
Okay. What?
She brings me to him and he takes off another body part.
So he's the one that says...
He's the one that says a toe, and then a foot, and now my leg, below the knee.
Anything else that he's done? He's sinister.
I have the suspicion he's a vampire.
Is that a metaphor?
No, like I think every time I go in for surgery, I think he's taking my blood. I think he's a vampire.
What do we do with the blood?
I don't know. I've never met a vampire before. I'm not sure what they do.
We can keep doing this for a while. It's like inside the actor's studio.
Thank you, our actor. All right, let's have our vote. How many think he has capacity?
Obviously.
How many are say no capacity? And how many are unsure? Okay, we have one sure. I think in the interest of time, I would just tell you our 4 scenarios. First one, he had capacity. Second one was unsure. Third one was no capacity. And fourth one, according to the ACE, if you actually did the, well, fourth one was not according to ACE, but sounds like you give your own assessment. You interviewed him.
We're winging it. But yeah, would probably lack capacity, although it's kind of complicated. There's a strong suspicion of psychosis. I wasn't sure where Matt was going to go with that, but
What were you trying to get me to say?
I know you just wanted to say that you thought I was a man. He's been dying to say that. It's in the script. But no, it's having an underlying psychotic disorder isn't always globally incapacitating. I mean, there are patients that are kind of quietly psychotic and don't really come to attention until a situation like this. And that's probably where we're going to be most helpful is a case like this. And then we really need to slow walk them through the decision-making process. If this is somebody, if it really is a fear that vampires are driving the treatment plan, then you do worry that the delusions are the thing that are influencing their decision-making and that they really may lack capacity. But if we have had patients where they have kind of all-encompassing delusional systems that are very elaborate, but when you walk them through the pragmatic issues of making that particular decision, they actually are intact. So this one, in a sense, is it can be a little more nuanced.
Back to the earlier point about depression being present. Lots of people have depression that have capacity to make decisions. What makes you nervous about a threshold where this person is incapacitated because of their depression?
I guess it depends on which one. There were the one where it's I don't know. Joe's point's a great one. It could be dimensions. Patient, no information is sticking. That person really can't make a rational decision because they can't retain all the facts. My worry, this kind of brought up a little bit, but my worry, particularly in older patients, a severe depression, that's a common answer. I don't know. It's reflexive. There is no effort at thought, and it's driven by this really severe depression that's going on. And again, that's where having outside informants is really helpful, and that's where a more thorough cognitive and psychiatric assessment needs to be done.
A question about when you said the first time he had capacity, and if they were allowed to go home and say, go home and never be, like we had a luxury, it seemed like if they were still in the hospital, we were still able to see him over days, but if at first, and he answered, and we said he has the capacity to make that decision, and then we discharge him to his family, he never is seen again, and then he dies of infection, are we saying that there wasn't the need to go do a deeper dive to see if that depression, where that was going to lead us, which it seems to have led us to this? I guess I don't know if I misunderstood when we said the first time. Could we have said he has the capacity and that's it? You can make this decision.
No, I think in all of the scenarios, there certainly could be the opportunity for deeper dive and more questions and exploration of what happens if we accept your decision. And to the point of, so if we think you have capacity to refuse the surgery and your gangrene gets worse or you start declining in health, are we going to institute palliative care, hospice referral, other measures to keep you comfortable while accepting your decision. So there's the exploration of the depression part of it, getting that clarification. But if we don't think depression is the factor, if it's a demoralization or he's just felt he's lived a long enough life and is willing to end it, how do we ease it into that
Gotcha.
position?
That was, okay, so the deeper dive is done. and that was-
Right, all presuming that there's more, not just the 5-minute interview that you witnessed. We only have 5 minutes, so I wanted to turn it over to Susan to tell us about how do we document this, so for the clinicians in the audience.
30 slides in 5 minutes.
Well, you can pick the highlight one. Do you want to do it from there or here?
Not to complicate things, but I will tell you that just because someone might have a perception that there's an ulterior motive by their loved ones, I mean, sometimes, honestly, we've had plenty of those situations. We've had situations where family members are wanting mom or dad or whomever to have procedures done because they're living on their disability, right? So if their disability check goes away, then their income goes away. So it gets really complicated, and you also have to consider, is that individual acting in the patient's best interest, right? But we don't want to complicate things, right? Okay, so documentation. Let's see. So I'm going to just jump really quickly to the EPIC Advanced Care Planning activity. So again, everybody knows that we want the individual to be able to make their own decisions if at all possible, right? But if that's not possible and we're questioning whether or not the patient has capacity, then there is a formal process that you go through. Now, the care team at this point is that the team, all members of the team can kind of participate in conversations about whether or not the individual has capacity, and those things should be documented in the record. But the actual formal assessment of capacity or incapacity and the certification of incapacity is the responsibility of the attending physician and a second licensed, independently licensed Maryland physician. So we're talking about Maryland law right now, okay? So if you have a patient who is able to communicate in some way, shape, or form, it's going to take two. If you have someone who's not able to communicate by any means, it only takes the attending physician. But you know, what is required is that the physician or physicians have to personally examine the patient, and then they certify incapacity in the ACP activity. So if we're talking to one of the physicians has to have examined the patient within 2 hours of the actual certification. Obviously, both have to have personally examined the patient and reached an independent decision that yes, this patient lacks capacity, but one has to have been done within 2 hours of the actual certification. And obviously, it's supposed to happen before a procedure moves forward, but there are exceptions, like if you have an emergency, and you know, again, if they're unable to communicate, it only takes the attending, or if there's an emergency, you go ahead, you take care of the patient, you treat first, and you document later. But please go back and document, because that's one of our issues that we've seen is something might be an emergency, but we don't actually, no one goes back and does those certifications after the fact. So there's always a question about whether or not residents or fellows, can they actually act as one of the certifying physicians, the second certifying physician? The answer is yes, but only if they are independently licensed. So they would have to have filled out an application with the Maryland Board of Physicians, and they have their personal license number, right? So you can't do it if you're acting under the hospital license. It won't work. And most are not independently licensed. So in EPIC, there is what's called the Advanced Care Planning activity. And you can get there by, for inpatients, you can get there through the admission or transfer navigator. And I don't know that you can really see this, but if you click on it, the boxes say capacity and ACP info. You click on that and it'll open it up. I'm gonna jump to this. Okay, so documenting capacity, 5 steps in EPIC. First is You have to open up the capacity and advanced care planning activity. You have to identify who is going to be your decision maker, and I'll go through it really quickly in a minute. You have to, only an attending has the actual authority within EPIC to click the box saying that there is capacity or incapacity, right? There has to be a note written, a certification of incapacity note, and the second physician has to, we use the co-sign functionality, but what you have to do, you co-sign, but you also have to attest, because that second physician has to, again, have personally examined. It's just not they're agreeing to what the other physician wrote. They have to do their own, but they co-sign and they have to attest on that ACP note. So you can get there by clicking on more, and it opens up capacity and advanced care planning. There are other ways to get there. Up in the header, it'll say capacity. You can click on capacity. It'll open it up for you. You have, I want to point out capacity and ACP information. There are a bunch of links there. That's where you're going to find your tips and tricks. You're going to have FAQs there. Those are all very helpful to assist in how to go about doing this. What you also have on this first page is the hierarchy. So who can be a decision maker? What's the hierarchy? So if you're not a healthcare agent or a guardian of the person, then these are your surrogates, and that would be your hierarchy. But going into patient contacts, you would actually check the box of who's supposed to be the decision maker. So it says active question mark. You would click that box. Once you've figured out that I've got, let's say it's the spouse. I don't have an advance directive. I don't have a healthcare agent. I don't have a guardian of the person. You say that a legally authorized decision maker would be the spouse. You would click on the spouse, and that would activate that individual as the decision maker. Okay, so the attending then would go into the capacity to make home care decisions section, and you have options, full capacity, that's already highlighted for everybody. And again, only an attending would have the ability to click incapacitated and or a needs review. So they would click on incapacitated, right? And then they go to the note, and there's the link, create capacity ACP note. There's a template with lots of smart phrases. It makes it easy for you. So you come in, and across the top, across the top, there are different things that you can do here. So there's a template for a Maryland capacity note. There's a template for a DC capacity note. There's a template for an oral advance directive, because we've also had challenges in the past of how do I go about documenting an oral advance directive. We built that in this activity. And there's a note for a patient regaining capacity. So first up would be selecting Maryland capacity note. Step 2 would be selecting whether the procedure is emergent, the patient's unconscious or unable to communicate, or all other capacity scenarios. There is a box there that says pull info in. If you click that box, it'll actually pull the information for the decision maker. Who you check the box of who's going to be the legally authorized decision maker. It'll pull that person's name and their contact information into your note. And then step 3 is your certification of patient incapacity. You check, we've got check boxes, and it's select everything that applies. If you have actually evaluated the patient within 2 hours, you would click that box. The patient examination was conducted within 2 hours of this certification of incapacity. Click the box, and then you sign it. You would also, if you need a cosign required, you would identify who your second certifying physician is going to be. When you identify them, it will drop the note into their in-basket. And again, what they need to do is go in, they attest. There's an attest button. When you open it up, there's an attest button. And then they write a brief note using, there's a dot phrase, ACP attest, and then you sign it. and you've got your 2 certifications. When all that happens, you will see banners, these yellow banners, and they show up in different places, but so they'll show up on the in the patient list, the summary, chart review reports, and again, it'll say patient is currently incapacitated. And you know, if there are no healthcare agents on file, what that means is somebody forgot to check the box, right? Going back to the patient contacts, they forgot, or you know, the various decision makers, they forgot to check the box. That means, but somebody did check the incapacitated. The attending did check the incapacitated, but they forgot to check the box of who your decision maker is. Okay. Yeah.
So I'll point out, just for our HBO policy, we have these algorithms. I won't go through them now, but it walks through all the steps that we talked about today. When do you raise red flags that the person might lack capacity? What's your bedside assessment? Is the case straightforward or not straightforward? And then walking through all of these steps and when you need to get additional input from consultants. And then how do you find out who the survey decision maker is going to be in that hierarchy?
What's the title in HBO?
It is the assessment of decision-making capacity. Just type in capacity and you'll get to it. And then summary, patients are presumed to have capacity until proven otherwise. We need 2 physicians to document they have incapacity. All team members can participate in helping the assessment. And then if they lack capacity, you need to find that authorized decision maker. Thank you all for staying extra time.